with the program that he's running right now. He has mainly done research associated with brain and spinal fluid issues. He did spend some time in the Navy, and he's been in Florida since 1996. There are 3 prominent brain diseases: Alzheimer's, which attacks the memory area of the brain and hence short-term memory loss; Parkinson's, which attacks the brain stem and hence loss of motor skills; and Lou Gehrig, which attacks the spinal cord and hence muscle loss. As far as Alzheimer's history, research started in the 1850s along with Dr. Alzheimer's research in 1906. Discovery in 1984 that amyloid in the brain clumps into plaque was a game changer, along with the world's first medicine in 2023 to slow amyloid in the brain by 20%. Risk factors: number 1, age. 60 million are over 65 years old, and we will reach 90 million in a few years. And number 2 is genetics. 70% of the cases are hereditary as far as it comes to Alzheimer's. Diagnosis: symptoms, physical exam, and a PET scan for amyloid are usually what's done first. Everyone experiences slight cognitive changes during age, so that's not to be not expected. Amyloid starts building up about 2 decades before memory loss starts, so I was surprised that it could start pretty early. Prevention: exercise, walk to 4-6 times a week, 30 minutes each time, socially engage with 5 groups and whatnot, keep your brain active, crossword puzzles and whatnot. I hate crossword puzzles personally. And diet: Mediterranean or U.S. version of this. Omega-3 and 6 fatty acids, plant-based micronutrients, and antioxidants are good. Some of the questions that were asked: any serious side effects from the Alzheimer medication that came out recently? Yes, you can get brain bleeds from that, which is why it is important to administer this medication along with the doctor's intervention. Are there any good brain supplements? Research has shown that the supplements do not necessarily improve brain performance, but that being said, if folks want to take them, like choline or resveratrol, that's fine, but better yet, it would be to have a balanced diet of fruits, beans, and whatnot that support brain health. Asked if you get involved with Village research in this area, and he said to contact his office. So you can see that there, and we have the information here as far as his phone number and his email address if you want that after the meeting. Is preventative research being done? Yes, various studies are ongoing on vaccines that might be an option for controlling amyloid. What is the cost of the Alzheimer's drug? It's about $25,000 per year. Hopefully Medicare will start covering it soon. Also looking at next generation drugs. And the last question was, how do you determine if you have Alzheimer's? There's a blood test that tests for amyloid levels in the brain, but Medicare currently does not pay for that test. And then we adjourn the meeting at 8:35.
Thanks, Rep. Can I get a motion to approve the minutes? Second. All in favor? All opposed? Okay, they're approved. Thank you. Next is our treasurer's report by our treasurer, Ash Mawa.
For the month of January, we had income of $13,113. We had expenses of $22,621, ending up in a negative cash of $9,508. Our operating account balance stands at $103,393. Thank you.
Thank you, Ash. Ken, membership chairman.
Good evening. We'd like to remind you that by joining the POA and paying your $15 a year helps us provide all the residents with a bulletin, and the other functions that we do helps pay and defer the costs for the shredding event and other events that we have throughout the year for the POA. And as a new member, you receive a bonus card which provides 21 different businesses within and around the villages that give you discounts. So for $15, it amounts to $1.25 a year. You get these benefits. And for those of you that would like to purchase a bonus card, we do have those for $5. And using them 2 or 3 times, you totally get your money back. After that, you have money put back in your pocket. So we would appreciate any support on selling these bonus cards also. Thank you.
Thanks, Ken. Okay, something I started to do, I don't know, a while ago, was introduce different supervisors and people that serve on different boards around the villages, so you guys get to know them. Sitting at the back table, our treasurer, Rep. Benson, is on the ARC, and also Jim Vaccaro in the red shirts on the ARC. I'm the AAC. I'm sorry, AAC. Got my groups mixed up. Also, Dan Warren's on NSCOD board. Jerry Felici's a District 5 supervisor. Mr. Cato, Gary is chairman of District 5. Steve is on District 7. I don't want to miss anybody because I get right. Mark is here. Mark's on the District 4 board, and I am also on the District 4 board. So just some of the people that do more to try to make this a better community. At the back table, we have our friends from Suncool, Seniors versus Crime, One Trust, Realty Execs. So they've been with us for a long time. I'm going to ask the people that are here and anybody that's watching this as we live stream our meetings, if you have any suggestions as to someone you'd like to see as a speaker, please let us know. We want speakers that interest the residents. And it gets hard, and I'm trying to think for all of you, and I don't want to do that. So please, you can either call me, you can send me a text message, you can email me. If you have a speaker, we'll try and get them. Believe me when I tell you. So if anything that interests you, just let us know. Okay, Ken mentioned our shredding event. We have a shredding event on April 20th at New Covenant Methodist Church behind Publix on 466. You need to be a member in good standing on the day of the event, which means your dues need to be current on April 20th. I will tell you that we probably will not make it through the month of March before I have to close it. We're getting close. We're at over 500 tickets so far. So if you're interested in doing it, send an email to POA for UYOU@gmail.com. If your dues are current, we will email you back a ticket. Just be patient. It takes me a couple of days to go through them all and do them. So I try to do a little bit every day. The good part about this is you're going to be able to come in your golf cart because this site is golf cart accessible. We've always done it at the Wildwood Community Center. And that wasn't available this year, and they did us a blessing in disguise by making us find another place that might work out to everybody's advantage and make it even a better event. So if you're interested, and just so you know, I saw an ad in Sunday's paper that there's a new pack and ship near the village of Fenney in 301. And they were advertising a deal. They had a sale. You could shred 10 to 20 pounds for 90 cents a pound, 20 to 40 pounds for 80 cents a pound. So figure it out, guys. For $15 membership, you could bring 40 or 50 pounds. It's a lot cheaper to do it our way. So if you're not a member, become a member, and then you can join in the shredding. Don't laugh, Gary. Our next meeting south of 44 at Everglades Rec Center will be on April 4th. Just throwing that out if there's anybody here from down there. We meet 4 times a year there. I would meet more often, but unfortunately I can't get rooms. Rooms are at a premium right now. As I stated a few minutes ago, our meetings are video recorded. You can go to our Facebook page, POA of the Villages, and you can watch the meeting at home, or you can watch it tomorrow. can watch it over and over and over again. I'm not going to ask Deb to say anything about Facebook tonight. Okay, Vial of Life. How many of you know what the Vial of Life is? Good. Anybody here in Marion County? Okay. In Marion County, it's called the Vial of Life. And instead of in a tube, it's a magnet with a little pocket on it that you put on your refrigerator. I spoke with Marion County. They know what this is. If you put it in your refrigerator and live in Marion County, they're going to know what to do with it. Believe me when I tell you. And I know that because I've had occasion to use it. What you do, comes with 2 sheets of paper. One of them asks for all kinds of medical equipment or information, your doctor. Fill that out, you stick it in that jar. And there's 2 green stickers. Put one on your front door and one on your refrigerator. EMTs walk in, and they're going to know exactly where to go. It's going to save you precious, precious time, and they're not going to ask you any questions. And when a loved one is suffering or hurt, you're a basket case. So make it easy on yourself, make it easy on your loved one. We have a whole bunch of them in the back. We're going to continue to do this until every household in the villages has one, so we'll be doing it for a long time. It's important. Today, just for your information, because I mentioned it last month, we had a multimodal path discussion group. Was anybody in this room at that meeting outside of a couple of supervisors? Okay, it was pretty interesting. Just a little background. Years ago, we used to have a multimodal path discussion group, and it sort of went away. And I don't think we've had one for about 8 or 10 years. And I started to try to revive it by going before POA and AAC, and got no for an answer so many times that it wasn't funny. But I persisted. And today, we had every district represented but District 9. So it's going to be we're going to do it 3 times a year. Staff is now working on to try to get us dates. So it's going to become a permanent thing. We meet at Everglades on whatever date they give us, usually at 1:30 in the afternoon. And it's important when we do this to get residents to come and give us their feedback on their concerns and issues with our multimodal path, because we have lots of issues. So it's just something that we keep working on, trying to make the villages a better place. And just for those of you that live in District 13 or in District 4, I have to tell you that on March 13th, District 4 will be holding a town hall meeting at 6:30 at Mulberry Grove Rec Center. Hope we get lots of District 4 residents who also give us their opinions and concerns as to things they think that need to be improved, changed, or done away with. Okay, we have a cash raffle. We give away 3 $30 prizes. Maybe we made some money today. I'm going to read the last 4 numbers. Please raise your hand if you have the winning number. 3651. Okay, we got a winner. Next number. 3387. Huh? Okay, Jerry, right here. First number was 3651. The next number is this lady right here, 3387. Right there with her hand up, second row. And the last number is 3689. where's that? Oh, Jer? 3689. First exercise he's done in a month. Okay, next on the agenda is what we call our open forum. Well, you can ask any question. Please don't ask a question if you think it might pertain to tonight's speaker. We will try and answer. If we don't have an answer, we'll get an answer to you or for you. So, if a couple of the board members could grab a mic and go out in the audience. Oh, okay. Okay, oh.
Cliff,
Gary.
what is the current circulation of the POA newspaper that's being distributed?
This month I'm ordering 70,000.
70,000. Wow, great. Thank you.
Well, they keep building more houses south to 44. Plus 4,000 emails. Thank you, Deb. Yeah, as long as they keep building. It gets worse. It's not easy. Anybody else with a question? Wow. Did someone say they have one? I don't see anybody's hand. Going once? Oh, this young lady.
Question, but I want to tell you about the vial.
Okay.
That I've loved ever since you started. I've been here. I'm in my 26th, ending my 26th year, and I've only been in the hospital one day for I was an in-out thing, whatever, and I had a January 30th. I had a freak accident in stepping on the trim of the living room hardwood floor to the tile, and it's curved, and I stepped in my bedroom slipper, and I went backwards, and I fell down on my rear end to my head. I've had a loved one until he deceased just a couple of years ago. That I was there for him to go follow ambulances, go to the hospital, everything. I was by myself. First, my watch didn't go off like it was supposed to, but I did have it on because I always have it on. I only take it off 3 hours in the evening when I'm just starting to watch TV. Otherwise, I wear it 24 hours a day. And it didn't do, like I said, but I was able to call out and happened to get somebody that was 4 minutes near my house, and I yelled to her, "I've fallen and I'm bleeding. Call 911 for me." And she did one thing. She told the operator, 911, to get somebody there right away because I'm alone and I'm bleeding, okay? Because we're busy with the ambulances at night now with the snowbirds in it. They can't come right away. So as it turned out, 3 policemen showed up at my door. I have a solid glass door, no frost on it. I want to see out, just many blinds that are always open. So when a flashlight, when I fell back into the living room, it was diagonal to where my face was facing the glass, the front door, and the flashlight hit my face, and I screamed out. My garage opener door, I had given it to the girl, but never mind. So the police was able to get in through there. And I knew, as bad as my puddle of blood that was behind my head, that I was probably going to be in the hospital overnight. So I'm telling one policeman, please go get my cell phone on the dresser on the bed. And I tell the other policeman, go into the refrigerator. On the refrigerator door, open it up, and there's a vial on there. Please pull it out, because I have everything listed and everything, okay? And so a little while later, I don't see, I said, did you get the vial? I have it on my door, I have it on my refrigerator door, and then it's sitting right there. As you open it up, it's right eye level. It was never gotten by the police at all. So I have a complaint there that we need to somehow get it to the police department to do their job when we do ours, so it will work. And so I just wanted to let you know that. I was a letdown because I was actually going to get to use it. Not that it's great to use, but yeah, and I did everything right.
Okay, I will have a discussion with Captain Seamer. That's not a problem. We will see if we can correct that. Anybody else with a question? Okay, seeing none, we'll get on. So next month, March, our meeting here, we have somebody from the Villages Hospital who was here last March, and the March before that, and the March before that. So hopefully they're going to upgrade some of the things they said last month, or last year. So we will see what happens. Cheryl Chestnut will be here, who's in charge of the hospital. In April at Everglades, we have Dr. Dr. Danielle Rozier, who's an audiologist. In April here, we have Edelman Financial is going to talk about some financial issues. Don't have anybody scheduled for May, but in June, here, we're going to have Len Hathaway who's going to do our lightning presentation again, and some lucky person who buys a raffle ticket is going to win a free lightning system, as we've done for the last 6 or 7 or 8 years. So we give somebody a whole system. Good price. So you might consider coming. In July, we have 2 meetings, one in Everglade and one here, and it will both be candidate nights for the candidates that are running for different offices, whether it be a district office or a county office. So that's going to take us up to July. So with that being said, our speaker tonight, who has been a speaker for us so many times, Dr. Norman Anderson, who does a great job and who has become a really good friend of mine. And I really am glad that you're here again and can't wait to hear what you have to say this time. Dr. Anderson.
Bring this up. I turned the juice off so I didn't lose any of the power. Please feel free to stop me at any point. If you get too annoyed or bored, I don't mind if you leave.
Dr. Anderson, I would prefer, though, if you do your presentation and then we'll take questions at the end, because
That sounds
we
fine
need
with
the
me.
mic there because we record it. So.
Yeah, I understand completely. Let me start off while this is heating up to talk to you about the lecture that I'm going to give. I've designed this basically as a non-professional lecture. Having said that, there is a professional version of this, which is about an hour long. I'm going to take about a half an hour. If you want the professional version, on the back table, I have put slips of paper with a QR code. All you have to do is to take a photograph of that. All you have to do is take a photograph of this, and the entire presentation will come up on Dropbox. You do not have to have a Dropbox account. I give you the lecture free of charge. I use my business Dropbox. But when you touch that, after you've taken a photograph of it, the entire lecture will come up. And as I indicated, it's about an hour long. The reason for doing that is not to stimulate business. Trust me, I have enough business. It's to save your life. And this lecture will become meaningful to you when you are the patient with melanoma, or it's a close family member or a close friend. Because what I'm going to show you has never been done in the history of medicine over the last 100 years. Nice view, huh? That's the trail that I rollerblade on when I go out to rollerblade. It goes from Dunellen to south of Inverness. The round trip is 94 miles. I have not rollerbladed 94 miles. I have done about 47 miles. So I've done half of the entire trip, but the scenery is absolutely beautiful. Let me give you some orientation as to the slides that you're going to look at. When a physician does a CT scan on a patient, imagine taking your body as if it's a deck of Kraft cheese, and you slice it. And every slice that you make, you can take that slice out and stand it up. When you look at me, my right side is on your left, and my left side is on your right. And that's the orientation that we have with the slides that you're going to see. So when I refer to the right side of the slide and call it your left, you won't think I'm crazy. I may very well be crazy, but this is left is right and right is left. When you do a PET CT scan, you're looking at the use of sugar. Cancer cells love sugar. It is the only source of fuel they will burn. They do not know how to metabolize fat. It takes sophistication to do that, and cancer cells are not interested in sophistication. They're only interested in dividing and growing and killing. And so what you will see with these slides is the use of sugar. Now, normal cells also use sugar, but they don't use quite as much of it as cancer cells do. The brain uses a lot of sugar, but it uses it because we're not eating the right amount of fat. And fat really doesn't kill. Fat is a problem if you consume fat in addition to the simple carbohydrates that you're eating. It's the simple carbohydrates that are going to kill you, not the fat. In fact, if you want to lower your cholesterol level and you want to lower your LDL, the best thing in the world you can do is to decrease the carbohydrates in your diet and increase the fat content. And most of the cardiologists will kill me for saying that, but I have the data to prove it. Regardless, when I show you some of these slides and I refer to the brain and there's a lot of brightness in that image, it's not that anything has gone wrong. That's normal brain cells. The same way that when we look at the heart is a muscle. It uses a tremendous amount of sugar, and it will take the shape, and I'll point that out. What we're really looking for when we do a PET CT scan is the use of sugar in the areas of the body that should not be using sugar. And since cancer cells love sugar, they're going to show up like bullets on the scans that I'm going to show you. The normal use of sugar for normal cells has a value of around 1 to 1.5. If you have an infection, inflammation causes white blood cells to come into the area and they use sugar, and the value may go up close to 2. If I tell you of a value greater than 2, you better be concerned that it's a malignancy or a cancer. And the higher the number is, the greater the likelihood we're dealing with a cancer. And there's one patient who's a resident in the Villages, who I will show you the images of, who had a value of 60, which means those cancer cells were using sugar 60 times faster than a normal cell would use it, and that gives you some idea of how aggressive the cancer cell really is. This approach for treating malignant melanoma at its site of origin, as well as disease spread using twice daily radiation therapy, has never been used before. What I am about to show you will cause you to think that this is unbelievable. But again, it's only going to have meaning when it becomes a close personal contact. Awakened at 2 a.m. by a phone call from a neurosurgeon, I focused on a 38-year-old whose history involved 23 masses from melanoma, forcefully compressing his brain. No known treatment could effectively address this burden. Our patient's initial adversity over 3 decades ago actually revealed the potential cure woven within our unique biology. Melanoma is primarily a skin cancer, routinely spreading to internal organs, commonly the lung. 325,000 lives worldwide, 100 in the United States alone, are diagnosed each year. Of the 57,000 annual deaths, 8,000 in our country continue to increase. In women, the rate has tripled. The highest annual incidence per capita is Australia, with Israel a close second. By 2040, without change, 96,000 are projected to die annually. In February of 2010, an 83-year-old gentleman presented with melanomas behind his left ear and scalp. Radical surgery with full-thickness grafting was followed by a second operation for further disease. Recurrences from March of 2010 through September of 2011 led to a total of 9 operations performed at the Moffitt Cancer Center. Immunotherapy was begun with significant side effects, short response, and rapid regrowth. As treatment was discontinued in December of 2011, our patient presented on self-referral in February and received radiation twice daily. No further pharmaceuticals nor surgery were ever used. This posterior view reveals the thickness of the malignancy, as well as the circled original site of continued recurrence. This is the appearance during treatment. 6 weeks after completion, it would appear we failed. However, let's follow our patient over time without further treatment. By January of 2013, physical examination revealed no palpable irregularity of the skin, but with visible fading of the melanotic pigment. Examinations and PET-CT scans found our patient 9 years from treatment without evidence of recurrence or further metastatic disease. They sent him home to die in approximately 3 months. No scar tissue formation, deficiency of taste, smell, hearing, sight, or ability to swallow ever occurred. Important is the time necessary to assess a complete response. If one were to biopsy the lesion within 2 or even 3 years following treatment, one may see cancer cells, but as time has shown, these cells gradually regress. Our 96-year-old, whose lesion of the right upper back proved invasive melanoma, a fungating mass involving the skin, was documented on PET-CT scan in March. Neither surgery nor immunotherapy were considered viable options. This is the appearance of the lesion at mid-treatment and 5 days following the completion of treatment. Due to her senior age, the patient passed in October from unrelated causes. The patient's nurse indicated the lesion had completely disappeared by the time of her death. Our 94-year-old's lesion was described as firm, hard, and infiltrative. Biopsy proved melanoma. Thickness was at least 13.2 millimeters, and the normal thickness of your dermis is about 4 millimeters. So this had gone well beyond that area. A PET-CT scan demonstrated no evidence of metastatic involvement. Radiation only was administered. This appearance 6 weeks, 4 months, and 7 months following only radiation treatment. Now approaching 2 years following treatment, he is without visible or palpable evidence of disease and no lymph node involvement. An 87-year-old presented with non-healing, rough, raised melanoma involving the left central frontal scalp. Examination, it revealed it to be 2 inches with 2 satellite lesions at its periphery, and 4.5 months following radiation treatment. Once daily radiation has been the standard of care over decades for malignancies of the head and neck, lung, and breast, but critical is the tolerance of normal tissue to withstand its delivery. Each organ has a unique ability to recover based upon the amount and volume of treatment that is delivered each time, as well as the total amount of radiation administered. Therapeutic radiation, delivered twice daily, began over half a century ago at the University of Florida and initially addressed head and neck squamous cell malignancies, cancers historically sensitive to once daily delivery. If the amount of energy were markedly reduced for each individual treatment, but administered twice daily rather than once, an increased total amount could potentially be given and possibly result in a higher cure. Decades of research were confirmatory, while less long-term side effects occurred to uninvolved but exposed normal tissue, reinforcing the approach's safety. Melanoma, in contrast, proved resistant, if not unresponsive, to conventional once-daily administration. If this had been discredited for 5 decades, the idea of reduced doses administered for melanoma twice daily would defy any logic. One would have to be an idiot to do that. And I was the first idiot to do that. But clinical experience becomes irrefutable evidence. For disease spread, let's compare treating metastatic melanoma using twice daily radiation at a specific time interval with those results obtained from pharmaceuticals, viewing complete response or continued regression, then progression-free survival with the ultimate goal of cure, all evaluated in light of cost. These are the complete disappearance rates using immunotherapy and targeted pharmaceuticals for treating melanoma. Many agents are combined in order to increase response. And initial complete disappearance is important, but cancers may respond over time if only an initial part seen. What I would like you to do is to focus on the percentages. Do not assume that immunotherapy is going to work great. Now, I am a strong supporter of immunotherapy, but we need to be realistic as far as what you expect as a patient that the drug is going to offer you. Personalized therapy presently offer extension with these 2-year survivals of roughly 40 to 60%. Other studies would indicate that by 3 years, approximately 40%, and by 5 years, 21% of patients are alive, having received 2 immunotherapy agents, with the majority of patients demonstrating progression. Now, I had this slide in before and removed it, but I put it back in for these reasons. The original article in the New England Journal of Medicine from latter 2022 showed that an agent called tumor-infiltrating lymphocytes did a much better job. And they compared it with another agent called Yervoy. The bottom line was there was a complete response or disappearance in 20% of patients receiving this medication, compared to only a 7% complete response in the other agent called Yervoy. But as the lower chart indicates, the rate of toxicity we call grading 1 through 4, that 3 and 4 occurred in 100% of the patients getting tumor lymphocytes. The reason I mention that is because this past week, the FDA approved the drug that involves the tumor lymphocytes. It's called Amtagvi, and the FDA approval was based upon a response rate of 31.5% in 73 patients who were compiled worldwide. This is administered once when all other medications have failed, and the cost is $515,000. Plus that, it requires the administration of both chemotherapy and interleukin-2 at the same time, and that requires a 5-day hospitalization so that the medications can be given IV. What does all this data really mean? A timely perspective is captured in this publication, where, quote, most patients with advanced disease will still experience progression on or after immune checkpoint inhibition, pointing to an unmet need for these patients with refractory disease. Symptoms of intracranial pressure led to an MRI in March of 2013, revealing a 3.7 by 3.6 by 3 centimeter mass within the left frontal lobe of this gent's brain. The white that you see around it is swelling or edema. Surgical resection was not performed, but biopsy confirmed melanoma. Twice daily treatment was administered from March through April of 2013. No pharmaceutical was ever administered. This gent was actually a former major with the Ocala Police Department. And in August, this is what life looks like for our patient relaxing in the mountains of North Carolina. A repeat MRI in December of 2013 demonstrated a residual 1 centimeter calcification with minimal swelling and no activity following a study using gadolinium, which confirmed there was no evidence of residual cancer. The patient remained without cranial symptoms, radiographic recurrence, or neurologic deficit. A 68-year-old presented in 2009 with a melanoma involving the skin of his right back. Removal and reconstruction at an academic institution revealed none of 4 sentinel lymph nodes to contain disease, but spread to the lungs resulted in respiratory failure 3 years later. A 6 by 5 centimeter mass in the upper right chest revealed a metabolic activity of 22 units. In other words, the cancer cells were using sugar 22 times faster than a normal cell. And you can see from looking at the upper left image that I was referring to something on the left side of the slide, but I called it the right side of his chest. Everything is reversed. Twice daily radiation was administered through January of 2013. The post-treatment PET-CT scan demonstrated tremendous inflammation, and that's the brightness that you see. But it was felt to represent more than just inflammation. The area of intense activity at the superior border of the middle image remained untreated because the academic center wanted to use that to evaluate the immunotherapy that was anticipated. Aside from the normal activity involving the heart, follow-up imaging demonstrates further response to treatment with eventual complete disappearance, having only received radiation. The patient declined the initiation of immunotherapy and requested this remaining solitary lesion seen in the middle images to be treated with radiation. It as well disappeared. An 83-year-old retired nurse noted an ulcerative lesion involving the skin of her right ankle in June of 2015, with subsequent swelling of her entire right leg. Biopsy revealed melanoma. A PET-CT scan in August demonstrated numerous active soft nodules involving the entire right leg. A mass in the anterior compartment measured 2 inches, encasing the femoral artery, and that's that bright bullet that you see in the image. An academic institution recommended radical dissection of the entire right leg into her groin. The patient refused. An immune drug could not be used due to her compromised kidney function. My physical examination in September of 2015 revealed marked swelling of the entire right lower extremity. Nodules on and below the surface of the skin were palpated all the way into the groin, with individual lymph nodes greater than 4 centimeters along the inner aspect of the right thigh. Radiation was administered twice daily. The post-treatment PET-CT scan on December 28th now revealed normal imaging following treatment. The right leg returned to normal size and was equal with that of the left leg. A very respected physician underwent removal of a melanoma from his left shoulder in December of 2009. In mid-2013, the left axilla demonstrated a 4-centimeter mass extending into the surrounding tissue. Surgical removal was incomplete as the mass invaded the chest wall. Twice daily radiation was delivered postoperatively. However, his first follow-up PET-CT, less than 3 months later in December, revealed a right upper lobe lung nodule with a brightness of 3.5. Our physician declined immunotherapy surgery or high-dose per fraction short-course radiation, but rather was treated with low-dose perfraction, twice-daily radiation alone. In April 2014, a post-treatment PET-CT scan demonstrated a decrease in both size and brightness. By July, there was no activity, but with the anticipated linear scarring, which is an indication of prior radiation. Follow-up serial PET-CT scans remained unchanged, but with the characteristic appearance of prior treatment. Now 10 years, having never received immunotherapy nor further surgery, without evidence of either local failure or metastatic disease. A 25-year-old was diagnosed with melanoma involving the skin of her right ear in 2010. Surgery revealed no lymph node involvement. However, progressive back pain in October of 2017 revealed metastatic melanoma involving her lungs, liver, adrenal glands, pancreas, and bone. Multiple procedures at leading medical centers addressed this involvement. 22 cycles of immunotherapy followed. A significant response was seen, but the PET-CT scans demonstrated progression involving the chest, upper abdomen, and lymph nodes. An immunotherapy agent caused side effects and was discontinued. In October of 2019, 2 immunotherapy drugs were initiated, but with subsequent hospitalization secondary to acute hepatitis. An initial favorable response ended in May of 2020 when imaging revealed extensive mediastinal and bilateral hilar adenopathy, which means the lymph nodes in the middle of the chest all the way into the abdomen were involved, and they had a brightness of 18.7 units. This involvement had actually progressed during the continued use of immunotherapy. At the age of 35, she was seen in June of 2020 and received twice-daily radiation. The lymph nodes diminished in October's post-treatment scan, with activity decreasing from 18.7 to 5.6 units. By February of 21, significant decrease in lymph node size and activity now to 3.6 was seen. Without evidence of disease at this time, she manages her business. Initial conversation years earlier raised concern for our single parent as to who was to care for her daughter following her anticipated passing from melanoma. The conversation now, 3.5 years later, involves selecting which university her daughter will attend, as both may very well live her future. A 78-year-old who complained of itching involving her scalp, unresponsive to topical preparations. Evaluation in March of 2019 confirmed a papule located within the left superior parietal scalp. Pathology revealed melanoma. Physical examination revealed the scalp lesion and 2 small satellite lesions of questionable significance. The PET-CT scan in March demonstrated the increased activity at the site of the biopsy in the upper image that you can see, with a value of 2.6. Unexpectedly, a 1.8 centimeter left lung mass with an activity of 5.7 was seen. A post-radiation scan in August of 2019 demonstrated no activity involving either the scalp or the left lung. PET-CT scans remained negative. Now 4 years from treatment for radiographically consistent stage 4 melanoma without evidence of disease clinically or by PET-CT. This is one of the most recent cases that I'm going to show you, and one of the most dramatic. A 78-year-old with chronic inflammation of the sinuses demonstrated nasal congestion, visual effect, headaches, and nosebleeds. Examination in July of 23 revealed a paranasal mass. The ear, nose, and throat doctor went into the right nostril and saw a mass growing in this entire area. it eroded through the septum, which separates the left and the right side of the nose, and invaded the left nostril. It ate through the bone into the maxillary sinus below her eye, and then it ate up into the orbital cavity and surrounded the optic nerve. And that's what you're looking at with those 4 images. The upper left one shows the cancer surrounding her optic nerve. She described lightning bolt pain as if someone was taking a dagger and constantly beating it into her eye. The activity in this area was 10.3 units. No immunotherapy was administered nor surgery contemplated. The ENT doc said in order to do an operation, they would have to start cutting here, remove her entire nose, the right maxillary sinus, her right eye, and cut up to the base of her skull, and it still wouldn't get all of the disease out. The PET CT scan 6 weeks following the completion of radiation demonstrates the prior abnormal activity to have completely resolved, as did the patient's symptoms. No further pain, visual impairment, or bleeding was experienced. All remaining imaging brightness was now normal in intensity, as what you see in the upper left image. On the posterior border of that, those 2 areas of brightness is normal brain activity. As pertains to side effects, she indicated that there was a temporary partial loss of smell, but it became evident because the constant bleeding stopped and she could actually breathe through her nose. She also noticed that some foods temporarily changed, and the reason they did was because the cancer had grown down through her nose into the hard palate of her mouth, and that had to be treated at the same time. Fortunately, she got all of her taste back. Now, Steve and I were in the Marine Corps. This lady was in the Navy. She used to call me Commander every time she came in for treatment. I told her, we don't have any commanders in the Marine Corps. She said, I know that, Commander. Because of the low dose per fraction of radiation and low total dose to the optic nerve, preservation of her vision with normal physical appearance is anticipated. Similar to the vast majority undergoing therapeutic radiation twice daily, the cost for this patient's entire course of radiation treatment was equal to that of 1 month of single-agent immunotherapy. Historically a rare occurrence, the abscopal or immune effect was described first in 1953. That is, as tumors diminished with the administration of radiation in one area, shrinkage of similar tumors elsewhere occurs, and I never treated it. And although this is a rare occurrence, what we found was that when radiation is given twice a day, 85% of my patients have developed this immune reaction, which means the immune system in that patient actually destroys cancers in areas I'm not even treating, and it's for free. A 63-year-old gentleman had an original skin lesion on his back that was surgically removed. Metastases to the lung were documented in early 21, initiating an immunotherapeutic agent. Progression of disease led to the addition of a second agent, but after 2 cycles, significant adverse neurologic effects caused discontinuation. The patient declined an oral medication and no further immunotherapy was administered when this PET CT scan in January of 22 led to self-referral in February, as 4 lesions had progressed during the time the immunotherapy was given, all involving his lungs. The 4th lesion approximated the inferior surface of the left ventricle, as shows up in the bottom image. What I did was I treated 3 of the 4 lesions. The one approaching the heart was not treated. And the reason why was because I wanted to avoid side effects to the heart. And if this patient got the immune response I'm talking about, the disease would disappear on its own. And that is exactly what time has shown us. The most recent scan done in November of 23 is without any abnormal activity, and in the lower image, the prior lesion approaching the left heart resolved without treatment, indicative of the immune response. With immunotherapy discontinued prior to his self-referral, the projected cost savings now approaches $1 million, and that saving is increasing. Our next patient's recent book documents treatment for his melanoma and his wife's treatment for breast cancer. Mr. Hutmacher's initial skin lesion was never found. At the time of his presentation, symptoms of right flank pain had begun in latter April of 2019. Destructive changes involved the L1 vertebral body, where the mass was 1.5 inches, compressing his spinal cord. Biopsy confirmed melanoma, and this is the patient with the highest level I have ever seen, of 60. On May 17th, surgical resection demonstrated metastatic melanoma with compression of the cord. When I did his planning scans, and he had already started on immunotherapy, I saw rapid regrowth of his tumor within 3 weeks of when the surgery and the immunotherapy was started. So in spite of immunotherapy, the disease had rapidly grown. The first post-radiation treatment demonstrated marked diminishment in the area I treated, but of concern was the spread to the upper thoracic spine and more than a dozen lesions in his lung. What I did was I treated the thoracic spine and 2 of the more than dozen lesions. The rest were not treated. Within 2 weeks of starting his treatment, the original skin lesion now showed up on the inner aspect of his right leg. This is the post-treatment scan in January of 2020, and it demonstrates the changes that will occur after radiation without any metabolic activity. Now greater than 4.5 years following radiation, our author is without evidence of disease. Immunotherapy was long since discontinued. Results from Vanderbilt University may indirectly explain this unexpected but obvious occurrence. Dr. Mary Phillip and Michael Rudloff published data in a magazine journal called The Conversation in August of 23, and indicated that although immune cells can recognize abnormal proteins on cancer cells and therefore have the ability to kill them, those same T cells become exhausted or non-functional by 12 hours after contact with a malignant cell, now demonstrating thousands of changes in genetic structure and expression. So, as she indicates, although this has shown significant promise, most patients and demonstrate T cell exhaustion as a major culprit. So if we apply this knowledge to the results of our melanoma treatment, when the interval of me administering the radiation is a short 4 to 6 hours, do we potentially overcome this T cell exhaustion, and thus evidence for the immune reaction now surfaces? And this is the first time in the world's history this has ever been documented. So if you want to prove that what I'm doing does not work, do the treatment every 12 hours, and I guarantee you the melanoma cells will grow right through what I'm doing. If you want to prove that it works, the interval cannot go longer than 6 hours, and in our office, it doesn't. Nothing in medicine remains 100%. Time must pass to see the involving results. 2 cases that I treated for brain metastases were large. They were centrally located within the brain. They could not be operated on before I treated. And unfortunately, because the cancer cells went away so rapidly, those patients bled and died. I have treated 108 patients so far to 171 geographic sites or regions. and we have followed those patients. Now, 80% with metastatic disease are alive at 3 years, which is twice as many as what the immunotherapy drugs will give you. The incidence of cancer in those patients is almost non-existent, and for the drugs, if they are alive, the 40%, almost all of them demonstrate evidence of disease. It just hasn't progressed to death. This is one patient that I need to show you who's a 95-year-old former executive with what used to be Florida Power Corporation. He had confluent spread of melanoma involving his entire left arm. It went from his hand all the way to the shoulder. He was evaluated by a leading academic center who recommended amputation of his left upper extremity. This is the appearance 6 weeks following radiation therapy. Now, the only obstacle in this man's case was he had this little ditzel remaining on the skin of his left arm. I had the dermatologist just remove a little bit of it. Immediately afterwards, the lesion regressed on its own, without any treatment. The question becomes, were they just tumor cells laying there, not the least bit active because they were already dead? It's just that his immune system hadn't dissolved it away until they were stimulated by the biopsy. He's now 2.5 years out with no evidence of disease. And if you compare that with a left upper extremity amputation, it would appear he made a good choice. Well, this final case clarifies for us what the effectiveness of twice-a-day radiation is, because this original diagnosis for this gent was made in 1997. He underwent surgery for his malignancy, and years later in October of 2013, he developed right upper quadrant abdominal pain. Lesions showed up in his adrenal glands. Both of them were biopsied, and they proved metastatic melanoma. That was when the immunotherapy started. The first drug did not prove to be effective, but with significant side effects. Keytruda, which is one of the most common immunotherapeutic agents, was started in February of 2015, and it did demonstrate a response with the right adrenal gland. The size of the gland stayed the same, but the activity went down significantly. What occurred in the left adrenal gland, which is that hot area, the bright area you're seeing, is that it actually grew bigger than it had before, which indicates that when cancer cells divide and grow, they many times change their genetics. We are actually looking at 2 different types of melanoma in the same patient, one of which responded nicely to the immunotherapy, and the other one that grew right through it. And that was when the patient was referred to me in 2015 to treat only the left adrenal gland. Although I wanted to treat both, they said, nope, he's responding well to the immunotherapy for the right. We only want the left treated. So I went ahead and treated the left gland, which you see is on the right side of the photograph. Not only did it decrease in activity, but it also decreased in size. 5 years later, the gent shows up not only activity in the non-irradiated right adrenal gland, but also this skin nodule on his right shoulder. So, in essence, the Keytruda had worked for up to 5 years, and at that point was no longer working. The activity in the area of the right adrenal gland had now increased to 10.1 units. The skin lesion had an activity of 9.9. The gent was treated elsewhere and not returned to me. Within 3 months of the beginning of the radiation once a day, you can see this humongous mass in the musculature of his right chest wall invading into his chest. And it had an activity of 18.9 units. When you look at the lower left image, that tiny little ditzel that I have left adrenal over it has an activity of 0.37, essentially equivalent to water. No evidence of disease in the gland that I treated 5.5 years earlier. The right adrenal gland, treated once a day, now had an activity of 10.7 units within 3 months of completing once-a-day radiation. So two things become obvious. The first thing is that in the same patient, treating virtually identical glands with immunotherapy, one responded well for 5 years, the other one didn't respond at all. The one I treated twice a day responded with no evidence of disease. Unfortunately, and he came back to see me after I treated this area of the right chest and stopped the pain and the involvement, other areas of his body progressed, including the right adrenal gland. Because it had been previously treated, I could not retreat again, and he subsequently died. Cost includes two factors. The first is that of the direct cost of the medication being prescribed, and the second is the medical intervention required to address the side effects. These are the monthly costs of immunotherapy. Many times they will combine two together. So Opdivo and Yervoy are used routinely together. The average cost is $53,000 a month, or roughly $600,000 a year. The average time for response is 2 years before the patient progresses and dies. In November of 2018, an article in the American Medical Association Dermatology publication by Dr. Ivo Abraham from the University of Arizona reviewed the annual cost for treating melanoma with immunotherapy, and he came to the conclusion that it was roughly $1.6 million per year per patient. Now, immunotherapy definitely has a significant role in many malignancies, and I will support that. But treatment with twice-daily radiation as an alternative for melanoma appears to offer optimum results while markedly decreasing overall cost to a few percent. This is my publication from a few years ago. I guess it's been about 3 years now. And at that point, I only had initial data. I was looking at about 30 patients. I now have 108. And I was referred patients not because it was a protocol, but because the referring physician did not feel there were any other logical alternatives. But as you can see, medical success with marked cost savings was uniformly achieved. This is a statement that what I've shown you is patented. No one else in the United States is allowed to do it. It would be a violation of federal law. I have patents in both the United States and Australia, and I have 34 pending in Europe. It's not to make money. It's because if you don't do this right, it will not work. And the guidelines are extremely strict. I know, having worked this out for 30 years, what each organ of the body can tolerate twice a day, what the doses are, what the volume is, and obviously the interval between treatments. Further specific details are, as I mentioned, if you photograph that QR, it will come up on your computer. It will be a much more complex and sophisticated lecture than what we've just talked about. But if that was to be given to a referring physician, they would want all the details, and they're all there. What you have seen is the clinical application of an energy whose origin occurred within the first moment of time itself. Hyperfractionation, which is what I have just described, differs biologically and immunologically from either conventional once-a-day treatment or what we call short-course hypofractionation, which has become very popular now. Large doses given over a short period of time. The collateral damage, which Steve and I had one obligation as fighter pilots to avoid, is that when you hit the brick wall at 35 miles an hour 5 times, you're going to have significant collateral damage. When you hit the brick wall at 3 miles an hour twice a day, you don't even dent your bumper, much less damage to your car. And that's exactly what I just showed you. And this is one of my grandchildren walking on the beach, and it indicates that twice daily radiation in this setting assumes an essential therapeutic role for melanoma and awakens a new horizon. Questions? Yes.
Just curious on the treatment.
Yes.
Radiation normally is just a few seconds, isn't it?
Correct. Most treatments are a minute to a minute and a half in duration.
So would you come in for a minute and a half, go home for 2 or 3 hours or 5 hours, come back for another minute and a half every day for?
Yeah, that's correct. That's your biggest side effect of the radiation is the sheer inconvenience or boredom of coming in. Fortunately, my staff is so pleasant. We have patients coming in early and staying late just because they enjoy being around us. And every one of my offices has a fireplace. So at this time of the year, many patients don't even leave. They just bring their books, they sit down in front of the fireplace, and they have a grand old time.
Are they normally coming in for 1 month, 2 months, 3 months?
Yeah, very good question. The normal time period is somewhere between 5 to 6.5 weeks. The number of treatments has nothing to do with the amount of radiation that you get. It has to do with how safely you're getting it. So smaller amounts take more treatments. Now here's the difficulty for an academic center. If you have to drive an hour and a half to 2 hours one way to get a treatment, and now they're going to tell you that you have to come in twice a day, 5 days a week for 5 to 6 weeks, you're going to say to them, I got to find a place that'll do it closer to home. I can't do this. They lose the patient. Now they say, well, wait, we have a new technique. We have hypofractionation. We can do all of this in 5 days, once a day, 5 days a week. And you're thinking, well, that's a heck of a lot more convenient. Okay, I'll take it. Well, for other cancers, like if you have a small ditzel in your lung, that could be a reasonable approach. There's nothing wrong with that. Biologically, for melanoma, that does nothing but inspire the cancer cells to grow. Does that make sense? It really doesn't make total sense to me that melanoma would be so different. And yet, this is not the only cancer I treat twice a day. If you come in with a small cell lung cancer, which is very aggressive and spreads, twice a day radiation in the medical literature has been proven to be very effective, and it's been used in countless centers. There are other cases I'll show you in another lecture of a breast cancer. It was just absolutely huge that it eaten through the patient's chest wall and invaded her heart. And every time her heart beat 80 times a minute, she felt pain. They sent her home to die, and I treated her. 10 years out, no evidence of disease, and she swims in her pool every day. So I guess I protected her heart at the same time that we took care of the cancer. But you see, I'm not doing anything magical. Stand back, look at the biology. Don't get hoodwinked into believing that new technology is the answer. We have the new technology, but you can't take Mother Nature's place. What was that ad years ago about parquet margarine? It's not nice to fool with Mother Nature. You lose. Respect the ability to let your body heal. Slow the car down to 3 miles an hour. It's inconvenient, but that fireplace is comfortable.
Yes, how does one know whether one has metastatic melanoma after removal of a melanoma lesion by a dermatologist?
Okay, well, and again, that depends on the approach that's going to be taken, because if it looks on the surface like this could be a deep-lying melanoma, my recommendation would be to do a PET CT scan before you go through that, because you see, once you remove the melanoma surgically, you have destroyed any immune response. There's no way to get a reaction. It's got to be stimulated with the radiation. So you do a PET CT, and then you determine, like many of the examples I showed you, there was no evidence of disease spread until we did the PET CT, and then, my gosh, just like that physician, the pediatrician, who, when we did it and it showed up in the lung, the academic center immediately wanted to do radical surgery to remove that entire area of his lung and put him on immunotherapy. And they told him, you will be on immunotherapy until you die. And so he said, well, what about Norm Anderson's technique? And they went, that's garbage. This is what you need to do. But we're going to follow you every 3 months with a repeat PET CT scan. And so every 3 months he went back to get a repeat PET CT scan, because they said, the moment you fail, we start the immunotherapy. That was the agreement. And he said, so in other words, if Dr. Anderson's technique doesn't work, and they said, there's no if, it's when. It's not going to work. 5 years later, they said to him, don't come back. You're cured. And then he said, well, what do you think of Dr. Anderson's technique now? And they said, those things happen. Yeah,
I saw a presentation you did about a year ago here.
yeah,
We were talking about tumor breast cancer,
yes.
which was absolutely amazing. I had known a lady who was given 6 months to live 12 years ago.
Mhm.
Had a tumor in the center of her brain, inoperable, and they said, start making the plans. Her husband researched and researched and researched, and finally found a place that did twice a day radiation. This is a long time ago, MD Anderson in Orlando.
Mhm.
She went 9 o'clock in the morning and 3 o'clock in the afternoon for months. You know,
Mhm.
they eradicated the tumor completely. She has lived another 12 years beyond the 6 months they gave her.
Yeah.
So I know it works. My question to you is this. Last week, we got a call from my daughter. She's been diagnosed with stage 1 breast cancer.
Yes.
We're just in the early stages of figuring out what to do.
Yeah.
The twice a day radiation on something of that size, I would think, in listening to what you're saying, certainly could work.
It could work, but it would be hard for me to justify putting a patient through that when the cure rate for her is so high with once-a-day treatment. Now, if there are other parameters that we look at in breast cancers to determine the aggressiveness of the cancer, if it's more aggressive, then twice a day becomes more of a need. But the vast majority of breast cancers are well treated with once a day. It doesn't require the twice a day. If a lady comes in like the pictures I showed you before, where she had let it grow for 20 years, and it literally dissolved her chest away, that's a different ballgame altogether. So most cancers are effectively treated once a day. When I see those with more aggressive tendencies, like small cell of the lung or glioblastoma of the brain, that is when I move into the twice a day. And in fact, the protocol that I designed over 30 years ago for treating the brain cancers, glioblastoma, is now being used by McGill University in Montreal, Canada. And they have combined what I laid out that many decades ago with the ketogenic diet, which is, again, a high-fat, low-carb. The idea is starving the brain cells from the use of sugar, because normal brain cells use fat beautifully. They love fat. And cancer cells can't use it. You eliminate the sugar, you start to starve them. You put them into this teeter-totter mode, and then with the twice a day, we shove them over the curdle. The normal cure rate for glioblastoma of the brain, 50% of the patients are alive at 6 months after diagnosis. No one's alive at a year. Of the first 18 patients I treated twice a day, 13 of the 18 were alive at a year. That's medically impossible. Is it where we want it to be? Absolutely not. Is it an improvement? Yeah. Same way with pancreatic cancers. Cure rate for pancreatic cancers is 3% of all cases. I'm running about 28% right now that are cured. And it's because we use it twice a day. Now, why do I use it twice a day there? It's because the bowel doesn't like radiation. You start increasing the dose and you start getting a lot of side effects. So if you're using small amounts twice a day, the bowel tolerates it. The teeter-totter stays in the favorable position. As long as you don't add too much for each dose and flip the teeter-totter, the tolerance of the normal tissue goes up. But it's not profitable. You don't make twice as much for treating twice a day. You get paid 1.4 times what you would have gotten. Well, when you look at your overhead, why would anyone do it? You're not making any more money. Maybe you're curing patients. So if that's your motivation. So I would always question when someone offers you a short course of treatment, because for each dose they give you, the percent of profit goes up. If you're dragging it out like we're talking about, it's not financially incentivized. Unfortunately, that is. It's the dollar and cents. And again, the logistics. And I can understand why the universities are taking that approach. They're going to lose patients. I was probably the greatest deficit that the University of Florida had when I came into private practice 38 years ago, because I offered logistical convenience. And up until that time, Rod Million, who was my mentor, treated all head and neck cancers twice a day. And his colleague, who he trained in Orlando, treated twice a day. And there was nothing here. So if you needed radiation for a head and neck cancer, you either went to Gainesville or Orlando, take your choice, and you would have gotten twice a day. Well, when I started my first office in Ocala, Logistically, it became more convenient, and I practiced medicine the same way I was taught. But you see, now the barrier comes into the logistics. So,
Do you ever consult with other physicians in other states?
constantly. I get calls from Australia, France, England, almost every week concerning the melanoma because they've seen the results. I just finished recently a treatment to a very, very wealthy Bulgarian businessman who came here with his entourage to be treated. And when we were teleconferencing before he came, I said, I will be more than happy if they speak English. I'll be more than happy to talk to your doctors in Bulgaria so you don't have to travel. And he and one of his sons laughed at me and said, we've already got our visas, we're on our way. And his brother-in-law is an ophthalmologist in the United States. So,
In layman's term, it sounds like what you're doing is equivalent to a vaccination,
yes,
which presents the immune system damaged villain that it can learn how to kill.
that is exactly right. And I honestly believe that is what, because again, those T lymphocytes that we're talking about, the T cells somehow become activated with this short interval between the first and the second treatment. Does it need to be researched? You bet. Do I think we ought to sit back until the research is done? Absolutely not. Because the field of radiation has been around for 103 years. This is not new. Madame Curie started this in 1921. And so we've had the time. We also know that the twice-a-day treatment has been in existence for over 50 years. So we don't need controlled randomized studies because they're basically used for pharmaceutical agents where you have to determine what the side effects are and what the benefits are compared to something else. We've got the research for over 5 decades to show it works. If someone wants to go on a controlled study, great. If someone looks at this data and goes, no, I know enough from what I've seen, I'll use that one first. If it doesn't work, we can go the other way. But to this time, in 108 patients, I have had a 100% complete response in every single one of them. That's medically impossible. That's why no one wants to believe it. It's too good to be true.
I believe it. What's really interesting is that in one of your cases, you treated one of the tumors, but yet another one also died. So the immune system in the body as a whole seems to have worked.
That is correct.
This is amazing.
In the patients that I have that I know have metastatic disease when I start the treatment, 85% of them have shown those results. Yes.
Doctor, how has radiation changed in the last 40 years? My father developed rectal cancer and was treated for that. He ended up with a huge ulcer at the base of his spine where they had to cut away his coccyx every couple of months. He eventually died from that. What has changed?
The technology has changed. We are now able to deliver more precisely the radiation. We don't get sucked in thinking that's the answer to the question. And the reason I say that is because that's what the manufacturer of technology wants you to believe. Somehow we can pinpoint the target and avoid destruction in normal tissue. You know, in the area that you treat, you're going to have collateral damage. That's all there is to it. What you have to do is to design the treatment to minimize, if not eliminate, the collateral damage. And that's why I always use the analogy for those patients who I've taken care of. The standard course of treatment is 5 to 6 weeks once a day. The analogy being you hit the brick wall at 5 miles an hour each time. And I know that's true, and the bumper will absorb the impact, because when my 3 children were learning how to drive, that's exactly what they did to the bumpers of my car, and it survived. But when you take all of the energy that you have used for that many times and you somehow squeeze it all down to one time, now 30 separate hits at 5 miles an hour each starts to look a lot like one hit at 150. What happens to the bumper of your car? And I don't care what technology you have. You can't build a bumper strong enough to absorb the impact without hurting the car at the same time. If you slow the car down to 3 miles an hour and hit the brick wall twice a day, you protect the normal tissue. So you don't have to have the most sophisticated, technically advanced equipment to get the results that I just showed you. You've got to understand the biology of what you're treating. I can take one of the cheapest linear accelerators and get those results. But if you're hitting the brick wall at 35 miles an hour 5 times, you better be pinpoint. Here's the difficulty with that approach to most cancers. Cancers are not like a little pea. If you put a drop of water on a napkin, the water spreads out. If the paper represents the normal tissue and the water represents the cancer, for a surgeon, they've got to decide where the water stops penetration. You've got to remove all of the paper to get the water away, or all of the normal tissue to get rid of the cancer cells. So the real question for the surgeon becomes, where do you stop? And in melanoma is because that water penetrates for quite a distance. Most surgical procedures for melanoma are big. They're called radical, which means wide. We're going to take a lot of normal tissue. Well, the beauty of the radiation is I can cover that big an area and not have to remove any of the normal tissue in the process, as long as I do the biology the way Mother Nature designed it. So it's not just technology. I do agree with the advancements in technology, but don't sell it. It's only part of the treatment. It's not the answer to the treatment. And advertising doesn't go along with that. Advertising means that if you get the best technology, your rates of cure go up. Bull crap. That's all garbage. It's the biology that makes the difference. And if we don't respect that, we're going to wind up being hurt. So if you're treating somebody's brain and you're doing it in a very short number of treatments, you cannot guarantee me that you have included all of the cancer cells, but avoided all of the normal cells at the same time. It's impossible. And you don't have to be a doctor to figure that one out. Common sense would tell you.
And Steve, that's the last question.
Is the no sugar, low carb diet part of your recommendations for all of your patients?
That's a good question. It depends on the type of cancer. If it's prostate cancer, most breast cancers, I don't push for that. If it's a glioblastoma of the brain, where I know that this factory up here for the cancer just soaks sugar up, and I know that normal brain cells love fat, that gives me an advantage. And that, I believe, is why McGill is using that in part of their study. It's been proven to be effective. Now, your liver will produce some sugar, so it's not as if you can eliminate it. But, you know, we could do a much better job as far as reducing the amount of sugar content. And people get misled. You are a baked potato. A baked potato has a glycemic index of 128. Which means it's 28% more harmful for you compared to sitting down and eating a bowl of sugar. Because the glycemic index of sugar is 100. So you want to really increase the sugar content and feed your cancer cells? Eat baked potatoes. A sweet potato has a glycemic index of 78, which means a sweet potato is by far better for you than a baked potato. Okay.
Well, hold on. Oh, hold on, sir. You need.
I don't have a question. I just want to tell you, sir, I'm proud. I'm one of your success stories. Thank you. 9 years ago.
Okay.
Thank you very much.
Unfortunately, time, it's 8:30, so we got to end it. Dr.
Yeah.
Anderson, again, thank you.
You're welcome. My pleasure.
We have donuts in the back. Thank you all for coming, and we'll see you next month, I hope. I know what he said.
Roll that sugar.